city called Ambala. So let's have, is Professor Liu is not here? Let's start with Professor Liu Zhugo's talk. Thank you. Oh no, this is the third speaker. The
Thanks, Chairman. First of all, I'd like to take this opportunity to thank the organized committee to invite me to speak here. Today, I'd like to talk corneal epithelial impairment. What should we do? This is my financial disclosure. As you know, corneal epithelial damage is the most common corneal disorders. Clinically, it presents in different forms and types. Proper repair of the corneal damage is crucial to maintain visual function. To treat these corneal defects, we like to treat the underlying cause, since it can lead to better outcomes. So based on the addressed the cause, the different treatment methods available, and the treatment including the three categories: the medical treatment and the surgical treatment and others. I'd like to introduce them one by one. For the medical treatment, the first we select is artificial tears. We usually select artificial tears according to the kind and the concentration of the electric and everything for different corneal defects. But most importantly, for severe corneal disorders, we only select no preserved artificial tears. For growth factors, and we know the growth factors are soluble circulating protein capable of affecting different cell process important for tissue regeneration. Recently, the ophthalmic agents of the growth factor has been drawing increased attention in clinical application such as EGF and NGF and FGF. For EGF eye drops, which are already available for more than 10 years in China, the result showed that the EGF eye drops can enhance the repairment of the corneal epithelium, increase the global cells density, and also increase the BUT. This is and one study showed the result. And for the BFGF, and this and eye drops also available in China for more than 10 years. As you know, the basic fibro growth factor is a growth factor distributed in different tissue, participant in processes such as cell proliferation and differentiation. It is mainly applied in tissue repair and regeneration. The BFGF and binding to the FGF receptor 1 to 4 activate downstream pathways and regulate cell proliferation, migration, metabolism, and extracellular matrix, and promoting cell survival. Our clinical study also shows the BFGF eye gel has been widely used clinically in the treat different of the ocular surface disease, such as corneal epithelial defect, punctal keratosis, and the corneal ulcer. Another study, which was finished by our group, also shows the BFGF and eye gel on the eye drops can increase the BUT and also increase human task and decreased corneal staining sclera in the dry and also another kind of the ocular surface disease. And also the BFGF can improve of the cornea conjunctiva cells. In this slide shows the growth of the conjunctival cytology was dramatically and decreased with use of the BFGF eye drops. For the NGF, we know the NGF have been confirmed it can promote the repair of the corneal epithelial damage in different situations and in different corneal defect. And our study in animals shows with the NGF, the corneal defect was dramatically improved with the NGF eye drops. And not only the corneal defect was improved, also the corneal sensitivity also increased. And in the clinical studies shows this is and the treatment also improvement corneal defect. This is one case we used and it with NGF eye drops for 3 weeks. After 3 weeks, the corneal defect was dramatically decreased, and also the corneal sensitivity was a little bit increased. And also we used the membrane extraction, and this one not commercially available, but sometimes can make in the laboratory. And we use this kind of extractor to treat corneal bone, and we found in animal studies show the corneal defect was dramatically an improvement after use of the membrane extraction. And this result is comparable with the membrane and the transplantation. And we use this kind of treatment for chemical bond patients in clinically. We observed 14 eyes and with severe chemical injury. After the treatment, we find that not only the corneal defect was much improved, but also the other data such as BUT and also Schumer test was improved. And this is one case, and before the treatment with a membrane extraction, and after treatment 1 day and 4 days, we found that the corneal defect was almost disappeared. There's another patient with the nuclear trophic keratitis. Our results also shows use the membrane extraction. This works very well. And there's another cases before the treatment, after treatment. And for the primary Sjogren syndrome, we also use this kind of treatment to improvement of the cornea and the defect. And there's a second Sjogren syndrome patients before the treatment and the 4 weeks after treatment. And the last medicine we use is a SUM. We know the SUM contains various cytokine, small molecular substances, etc. And we use this kind of to treat with severe and the corneal defect in clinically. So this is one case, and before the treatment, you find that the cornea and the epithelium was severe and defectively, and the first staining was severe. So after treatment for 10 months, we found the corneal epithelium was much improved. And in China, we also have the developing the careful bladder extra eye drops. And this one is commercially available for almost 10 years. We use this kind of treatment to treat Sjogren syndrome patient. You see that before the treatment and there's after treatment, this picture shows 2 months later. we found the cornea and the epithelium was much improved. So if the patients have a severe corneal and defect, and we also need to use contact lens. Now the contact lens and works very well for some patients with severe and defect, and also the patients feel very uncomfortable for the strong sensation of the foreign body. For some patients, when we needed to do the surgery including the membrane transplantation and the membrane and the covering. This two surgery is suitable for patients with corneal epithelial defect who do not respond well to drug treatment. The indication for a membrane transplantation and the covering are different. A membrane covering is suitable for patients with a corneal epithelial defect but intact corneal stroma, where a membrane transplantation is suitable for patients with damage to both the corneal epithelium and the stroma. So for this kind of surgery, the postoperative follow-up is critical. Most of the patients can achieve a good result. So in summary, we know the corneal defect is a very common ocular surface disease. And so promoting the corneal epithelial repair is very common in ocular surface clinical practice. Firstly, eliminate the cause of the corneal epithelial repair, and then with choice appropriately treatment methods based on different cause of the disease. And there are already have multiple methods, and we need to combine them and also comprehensively evaluate the advantage and the disadvantage of different treatment methods to make a scientific choice. Thank you very much for your attention.
Thank you so much. With this, we come to the next talk. Is by Dr. Namrata Sharma on artificial stroma. And we are seeing this beautiful meeting, and Dr. Sharma and the whole team is behind that work. Yeah. Yes, please.
The mic is not working. So my observation about dry eyes is that the pollution thing in the air is affecting the eyes indirectly or directly. So directly we know the pollutants, they come into the eye and cause irritation. The second way, indirectly they are affecting the this eyes is through the nose. With pollution, there is hypertrophy of the mucosa of the nose, blockage of the nose, polyps, this, that, and ultimately it leads to the dry eye. Very lately in America, they have found some drops, nasal drops, which they put in the nose, and that relieves the problem of dry eye to some extent. So when we take history of the patient, we should be asking something about if the patient has some nasal problem or not. It should be treated along with. So this is my observation.
True. And I think there are some nasal stimulators also. They help in the dry eye part.
So thank you, Vikas. I'll be talking about stromal implants basically and the bioengineered corneas that we are working on. And there are limitations of the human donor cornea because the limited supply of donor corneas is there. Risk of graft rejection, apart from which there are post-op complications associated with sutures and wound healing, risk of corneal neovascularization, high astigmatism after suture removal, need for long-term topical steroids, and necessity for long-term patient follow-up. So replicating corneal stroma, there are challenges. It's a complex structure, needs mechanical strength and transparency. And biosynthetic corneas have evolved from polyuria substrate and synthetic polymers. Ideal substitute is biocompatible, transparent, strong, non-immunogenic, refractive, permeable to nutrients and oxygen resistant to neoangiogenesis. What we are working on is the clinical grade collagen type 1, which has collagen solution cross-linked using cross-linked agents, and essentially looks like a soft bandage contact lens, comes in 12 millimeters diameter, thickness varies from 100 to 500 microns, shelf life is 2 years. So one has to do the quality check in terms of biological safety, in vivo evaluation of this material which has already been done, and ex vivo analysis of the also in the animal model. So we see the light transmission, it compares very well with the human cornea. And if you see the scanning electron microscopy, then it is very much like the porcine cornea, except that the fibrils are a little thicker and the space is also a little more in BPCDX cornea as compared to porcine corneas. Adhesions are quite good. Epithelium adheres quite well to it. This is control and this is BPCDX. And we've done studies, animal studies on the corneal thickness of the pachymetry as well. Then HNE or HNE epithelium and stroma staining has also been done, and immunohistochemical analysis shows that subbasal nerves are preserved in the BPCDX cornea. These are the parameters which are used by femtosecond laser to create the pocket, and this is how the surgery is done, and that is the femto pocket is created first, followed by the opening of this pocket from one end to the other, and then this biosynthetic cornea is folded and then is unfolded inside the eye, and then a bandage contact lens is applied. This is how the sandwiched cornea and intrastromally looks like. This is yet another case of keratoconus and pellucid marginal degeneration, where again in this we've customized the pocket to be a little more peripheral because the thinning is present right up to the periphery. So this goes right up to the periphery, and then subsequently again this is opened up. Subsequently again this pocket is opened up from one end to the other, and the biosynthetic cornea is then placed intrastromally after measuring the size of the pocket. And this patient also had cataract, so we've done this down the line, 3 months down the line, and this is quite clear except that there's a small rim which is present here. So post-operatively, if you see, this is third case of keratoconus in which this biosynthetic cornea was done, and from 85.9 the K came down to 57.1. Another case of intrastromal biosynthetic cornea. In fact, this is that longest case, which shows that you do have some channel deposits like you have, in the channels of the intracorneal ring segments, but apart from that, the interface is quite clear. Now, even in post-LASIK ectasia, we've used this. So we elevated the flap in the case of ectasia, and then created the pocket all around. Subsequently, the biosynthetic cornea was trephinated, was put in the interface, and the flap was put back, which was then sutured. This is how the case looks like in the post-op period, and K from 89 it decreased to 50. It decreased to 50.4, and pachymetry increased from 241 to 580 microns. Even in cases where you have anterior corneal haze like this, there also these biosynthetic corneas can be used because the epithelium adheres well to it. And so in this, we did use biosynthetic cornea. We actually glued it because it's difficult to suture. And after gluing it, a bandage contact lens was put on the sides, and it did take some time to epithelize, more than otherwise what would occur. It took a couple of weeks to epithelize, but epithelium does cover it, and this is in the post-op period, and this is how it looks on the AIOS2025-GP40. So if you look at the confocal microscopy, you can see the endothelium below it and the nerves above it, and I think future would be that we use these stromal substitutes so that we don't have to depend too much on the human donor cornea as well as the preservative media. And this study was in fact taken in 2 cohorts, ours and in Iran, and the biosynthetic cornea is the brainchild of Dr. Mehrdad Rafat, who is in Sweden, and we published this in Nature Biotechnology, which has an impact factor of 68.1. So now we've done close to 70 cases, and we didn't have to extrude any. For one patient, we did have to do a deep anterior lamellar keratoplasty, but apart from that, there were no complications. Now, we also compared the efficacy and outcome of biosynthetic cornea versus the human donor cornea in cases of keratoconus. So, cases were taken, there were 20 cases in each group, and best corrected visual acuity was comparable. There was no difference in pachymetry as far as the thinness pachymetry was concerned preoperatively, as well as the central corneal thickness. And this is the one which we've done with a biosynthetic lenticule. Astigmatism, again, there was no difference for change in astigmatism after 3 months follow-up. Anterior curvature flattening was comparable between both the groups, so were the average corneal higher order operations, and this is how the biosynthetic cornea looked like. So the only difference that we found was that the pachymetry was significantly more with the biosynthetic cornea than the biolenticules, because over a period of time, now we have 1 year follow-up, the human donor cornea tends to show some attrition, but doesn't happen with the synthetic lenticule, which remains very much the same thickness. So I think there is feasibility of distributing these bioengineered corneas, which is not dependent on human donation, and there is no graft rejection, suture related problems, and no eye-bank facilities required. And it does not preclude a human transplant if there is a complication. And I think once you have stromal construct on that, you can grow the endothelium. That would be the real cornea or the complete corneal construct. So to conclude, use of new bioengineered corneas for intrastromal keratoplasty is feasible, safe and simple technique for corneal ectasias, and when compared with human donor corneas, they are tectonically better supported. So thank you very much for your kind attention.
Thank you so much, Dr. Namrata Sharma, for fantastic talk. So just a couple of questions. Do you felt that was there any shrinkage of this collagen later in maybe 1 year, 2 years down the line? So whatever pachy you have got over a period of 2-3 years, was there any change?
So there is a slight change in pachymetry. There is no shrinkage of the collagen of the synthetic cornea, and it remained pretty much the same. But there was, with this biosynthetic cornea, now we have a follow-up of almost 7 years, and the study that we did was we have a follow-up of 1 year. So we are looking at both of them and prospectively following, but from the 7-year follow-up, the synthetic lenticule does not change, and we thought that there might be some attrition above or below it, but that was also not significant.
And did you, since there was not much of change in the keratometry and astigmatism, and we also found the same when we did human cornea, so did you consider doing a topo-guided PRK later on to?
No, that we did not.
But you have enough, like 140, 150 microns above it, that you can always do that.
So that is something which we are going to look at in future, but as of now we have not done.
Thank you so much.
Yeah, I agree. I think we had this discussion some time ago, if this is going to be amenable to any refractive procedure. I think instead of trying it on a human eye, it might be a good, because my worry is the collagen might start melting with laser. It might not happen. But yes, it'll be interesting to see that.
We have done it, but in those we have used only human cornea, and we have done 3 or 4 patient TGPRK, but along with that we did a cross-linking as well, and they did decently well with improving the surface as well. Next.
All right, I'd like to invite the next speaker, Dr. Yuchi Liu from Singapore. She's going to talk about phenylfibrate as a potential treatment for diabetic ocular surface and corneal neuropathy.
Okay. So thanks for the kind invitation. Oh, right. Right, so thanks for the kind invitation. So these 12 minutes, I'm going to share with you this topic, phenylfibrate as the potential treatment for diabetes ocular surface and the diabetes corneal neuropathy. I'm Yuchi Liu from Singapore National Eye Center. So we know diabetes neuropathy is one of the most common microvascular complications in diabetes, and when it occurs in cornea, we call diabetes corneal neuropathy, DCN. And DCN and its resultant diabetes keratopathy affects up to 64% for the patients with diabetes. This is one of the most common causes of neurotrophic keratitis. And we see these patients sometimes they came to clinic quite late because these patients have hypoepiphysia, so quite often these patients are underdiagnosed. So despite the medical and the economic burden, the current unmet need is we don't have the treatment to address the underlying neuropathy. What we are doing now is a symptomatic treatment. We give patient lubricants, we give patient prophylactics, antibiotics, but we are not addressing the underlying neuropathy. So we know topical NGF oxalate is one treatment option to stimulate the nerve regrowth, but it's very expensive and not available in all the countries, including Singapore. So that's the reason why we start to look at alternative, including fenofibrate. Fenofibrate is peroxisome proliferator activate receptor alpha, we call PPAR alpha. And our previous work has demonstrated PPAR expression was decreased in diabetes patients, as you can see in this immunostaining. And fenofibrate is an existing drug that we treat hyperlipidemia. It's a lipid-lowering drug. So what we are doing here is drug repurposing. More importantly, one landmark papers published in Lancet is fenofibrate can reduce the incidence of a peripheral neuropathy and reduce the rate of amputation. So that's the scientific rationales of this study. So in this clinical trial, we recruit 42 diabetes patients and 40 healthy controls. So it's an intervention study. We gave these patients oral fenofibrate treatment for 1 month's time, and these are the inclusion criteria. Before and after treatment, we did ocular surface assessment, including corneal sensitivity, Schirmer test, tear breakup time, cornea and ocular surface staining, as well as the patient's subjective symptoms using OSDI scales. We also send patients for in vivo confocal microscope and look at their corneal nerves, corneal epithelium, as well as the dendritic cells. And then we also collect patients' tears and they send for proteomics analysis. So these are the softwares we use to quantify 7 corneal nerve parameters, including, for example, corneal nerve density, corneal fiber density, and fractal dimension, as well as 5 parameters for epithelial cells, such as the size, the circularity, and the density, and dendritic cells, for example, the elongation, the density, and the cell count. So let's have a look at the results. We found that diabetes patients, as we expect, patients present with significantly lower corneal nerve density and fiber length, as well as more tortuous nerve, more nerve bleeding, and more swelling of the nerves because of the underlying neuropathy. But after treatment, we saw there's a significant improvement in the corneal nerve fiber density, and the risk for parameters also have an increasing trend. The epithelium, corneal epitheliums, we saw diabetic patients have more swelling of the cells because the AGE accumulated at the epithelium barrier. And after the treatment, we saw these cells become more regular, evidenced by the decrease of the circularity, and then the cell density become more compact. And more importantly, on ocular surface evaluations, diabetes patients, as we expected, these patients have a decreased corneal sensitivity and worse tear breakup time, ocular surface, and the corneal staining compared to healthy subjects. But after the treatment, as you can see, their superficial contact keratopathy significantly improved, evidenced by the reduction of the OSFR and ANI scores. Tear breakup time also significantly improved, suggesting more stable of the tear film. On the molecular levels, we found that diabetes patients have a significantly lower tear substance P concentration and a higher nerve growth factors concentration compared to healthy subjects. But after treatment, the substance P concentration significantly improved, and the least changes of the substance P is significantly correlated with the improvement of patients' nerve density. And we also look at patients' tear proteomics analysis. So this is a typical volcano plot showing those significantly up and down-regulated proteins. And if we look at the pathway analysis, we identify 4 major pathways that can explain the neural protection and the nerve regeneration effects of phenylfibrate. So number one, it upregulated the neuronal pathway. Number two, it modulates the lipid metabolism. And number three, it suppresses the inflammation. Number four, suppresses the coagulation ratio as well. So we're quite interested in these anti-inflammatory effects, particularly because we know many ocular surface diseases actually related to the chronic ocular surface inflammation. But if we look at the previous publications, the anti-inflammatory effects of phenylfibrate actually has been demonstrated in animal models of many chemical injury, but all of these data were actually published based on animal models. So we went back to look at our clinical cohort, and what we found is these diabetes patients present with significantly more dendritic cells. We know dendritic cells is an indicator, a marker for inflammatory reaction. So diabetes patients have a significantly higher dendritic cell density compared to healthy controls. But after treatment, you can see the dendritic cells density significantly reduced. And these dendritic cells elongation and the length also increase, suggesting they have shorter dendrites. That means the phenylfibrate shift the dendritic cells into more immotile phenotype, suggesting the underlying neural inflammation was suppressed. Then we also look at the tier, those inflammatory markers, for example, TNF-alpha and FKB, complement cascade, and we found those inflammatory markers are significantly suppressed after the treatment, while those anti-inflammatory markers such as interleukin-1 receptor agonist increased after the treatment. So these are the paper and some median release we published. So after these promising results, the next questions to me is actually whether we can make the oral phenylfibrate into a topical formulation so that we can eliminate the side effects from the oral intake, such as nausea, vomiting, constipations. And topical formulation will also improve patients' compliance, will be better for the future clinical adoption. And theoretically, the topical formulations will achieve higher drug concentrations in the cornea and therefore achieving better efficacy. So we further formulate oral phenylfibrate into a topical formulation and test it in the diabetic mice model. And what we found is after the topical treatment, we see the corneal nerve matrix also improve, evidenced by the increased corneal nerve fiber length density and the less tortuosity after 3 months topical treatment. So this is demonstrated by the not only confocal scans but also the whole mount tubulin staining, which is the neuronal markers. Clinically, these mice corneal sensitivity also significantly improve after 3 months topical treatment. And on the epithelial analysis, so similarly, we see the cell density increase, the cell morphology become better, and the surface punctal keratopathy staining decrease after 3 months treatment. And this improvement is earlier in topical treatment compared to oral phenylfibrate treatment, probably because the therapeutic concentration will be higher in the cornea. So similarly, we look at the tier proteomics profiles, and the mechanism is quite similar as what we found in the clinical cohort. So it enhances the neuroactive reaction and at the same time suppress the inflammatory status. So what we are doing now is we further nano-formulate these phenylfibrate eye drops. As you can see in the picture, and we help to enhance the ocular penetrations as well as the bioavailability. That is the topical eye drops. For the oral phenylfibrate, we are planning a multi-center randomized control trials to further validate our results using larger cohort. And more importantly here is we are doing drug repurposing. So we know for drug repurposing, the risk as well as the timeline to develop the new drug is much less compared to exploring a new drug. So that's the advantages. So to conclude, phenofibrate enhance corneal nerve regeneration and ameliorate the ocular surface inflammation in diabetes cornea through the neurotrophic reaction, lipid modulation, as well as anti-inflammatory reactions. Either topical or oral treatment can be explored as a novel treatment as a new treatment for diabetes corneal neuropathy or diabetes keratopathy. And phenofibrate stands a more favorable position because in this case it's a drug repurposing. So thank you very much for your attention.
Thank you so much for that comprehensive talk. Thank you so much. Yeah. So maybe for the next talk, can we invite Dr. Sayan Basu for his talk on corneal stromal regeneration?
Good afternoon, everyone. Thank you so much for making me a part of this session. My apologies to those who heard this talk earlier in the morning session, but you can never have too much of a good thing, so I'll go at it again. So I'll be talking on corneal regeneration using stem cells and 3D bioprinting. In my presentation, I have the following disclosures because of patents on some of the products that I'm going to speak about and the funding disclosures. So this is part of the work that we do at the L.V. Prasad Eye Institute on corneal regeneration, which also includes the work that I'm presenting today on the corneal stroma. We are able to do this because of the translational research pipeline that we have been able to put together in the last many years for bench to bedside or translational research, which has the basic science labs on one side where we do proof of concept testing, identifying newer mechanisms, targets, molecules, delivery systems, and then validating these through a set of preclinical and clinical studies. So for preclinical studies, we have organ-on-chip, in vitro validation, the zebrafish, the animal labs, and we also have an on-site GMP manufacturing facility, which is very critical to investigational new drugs like the ones that we are going to talk about today. And then we also have the setup for the phase 1 to 3 clinical trials. Now, the roadmap and the guiding principles that we follow for this translational research is basically hinged on two critical aspects. The first is that we try to identify a problem that is important and relevant to India and to the rest of the developing world. And the second is that we try to find a solution that is both affordable and practical. Affordable because we don't want to develop a product that is so expensive that may be miraculous, but so expensive that it is out of reach of people who actually need it. And as we all know that in India and the rest of the developing world, patients are paying out of pocket and they cannot afford very expensive therapies. So the problem that we identified to work on was corneal blindness, especially with respect to corneal opacification. The reason for that being that corneal opacification is the primary cause of blindness due to corneal diseases in India and the developing world. This is very unlike what we see in the West, where endothelial disease is overwhelmingly the most common cause of corneal blindness disease pathology. So our problems are different and we need to look for different solutions. The reason that penetrating keratoplasty is not going to do it for us is because a lot of these opacities carry a poor prognosis for long-term penetrating grafts. And there are many ways to look at approaching this limitation of keratoplasty as a solution for corneal blindness. The most popular of which is developing different forms of lamellar corneal surgery, which all of us have been doing for the last decade and a half. But there are limitations to that as well. You have keratoprosthesis, which over time has become more reliable and safe, but there's still a long way to go. And what I'm going to talk to you today are the alternate approaches which are on the right side of this slide, which include stem cell therapy and bioengineering. So if you think of the stroma, since we are talking of corneal opacification, which primarily affects the stroma is mostly extracellular matrix. interspersed with a few cells which are of mesenchymal origin, which are mostly keratocytes, which basically produce the axonal matrix. So if you think of corneal stromal regeneration, you can either think of replacing the cells with better cells that can make a clear or modulate or remodel deranged axonal matrix, or think of replacing the axonal matrix, or replacing the entire stroma with a combination of cells and axonal matrix. So you can think of it as cells, gel, or cells plus gel, or cells incorporated in gel. The other thing about opacification is that sometimes we think of corneal scarring only as the opacity, and the remedy to corneal scarring being getting rid of the opacification. This is a little simplistic in my opinion, because a scar is more than an opacity. You also have thinning of the cornea, you have flattening of the surface, you have irregularities in the surface, and just rendering the corneal stroma transparent will not necessarily result in the patient seeing better. The best example of this is keratoconus, where you can have an optically clear cornea, but a cornea that is so irregular that the patient has poor vision. So when we think of regenerative therapies for corneal opacities, we also have to think of the other attributes which are contributing to poor vision other than the density of the opacification. So we have developed some metrics of quantifying what the scar is in terms of both the density of the opacity, also the thickness, and also the surface irregularity. And when we apply these therapies, we look at improvement on all of these parameters, not just the removal of the opacity or clearing of the cornea. So the first approach is using cells, which is based on work that I did many years ago at the Funderburg lab in Pittsburgh, where they identified these MSCs in the peripheral cornea and later on isolated at the limbus. So these are called limbus-derived MSCs, which have properties, wound modulating properties, that can get rid of corneal stromal opacification, both developmental and acquired. So we have just completed 2 clinical trials with preserved and unpreserved HLMSCs. These are the first Indian FDA approved open label phase 1 clinical trials with the current regulations, which had 20 patients in each trial. We worked on patients with post-infectious scars, ulcers, and burns. We completed the 2-year safety study on 14th of February of this year. We'll be presenting the detailed results at the ARVO meeting this year, so those of you interested can come to our poster. So essentially, alginate is important in this story because it allows us to preserve and transport the cells without requiring a cold chain. Cutting the cold chain off is important in our context because it makes the therapy more affordable. The costs are less because you don't need to transport the cells maintaining that cold chain. They can be transported at room temperature, and we have shown this before, that they can be transported in Indian summer conditions for 3 to 5 days without losing cell viability. So before we went to the clinical trials, we had to establish the safety of the GMP manufactured cells, which we did in 2 animal models, the efficacy of the cells working on both scars and preventing scars from happening in an acute state of injury in, again, 2 animal models, and then have a system and a process where we could manufacture these cells using xeno-free, serum-free conditions, which makes the product safer because you are not using any animal products, you do not depend on any human or animal-based serum. So this is how the cells are manufactured. You basically start with a corneoscleral limb. Like I mentioned before, these cells are derived from the human limbus. We take a small limbal biopsy, cut it up into pieces, digest it, and then these cells are grown in the incubator. Initially, when the cells grow out in culture, you get a mixture of mostly epithelial cells, but with serial passaging, you can get a pure population of these cells, and this is how it is sent to the operation theater for me for transplantation or application. The application is topical, and it is also, like I said, the delivery is very simple. Here you can see that I have, under topical anesthesia, just removed the epithelium with a sponge, and the cells are mixed in one of the components of commercially available fibrin glue, which is then topically applied, and the glue sets it in place. And at the end of application on the area that you're interested in, and you can do a more widespread application in burns or in other pathologies, you put a bandage contact lens and then give the patient prophylactic antibiotics for 1 week, no other medications. So we have been very satisfied with the results that we have so far, both in acute inflammation and also in formed scars. And typically we see an improvement in uncorrected, best corrected vision, and also in the density of the opacity, and also somewhat in the surface regularity in these cases. So this is a typical example of a post-infectious superficial corneal scar, preoperatively and post-operative, where you can see that the opacification, and in this patient the vision also has improved with single application. The cell seems to be most effective where you have acute inflammation, like in this case of a Hansen's patient with persistent epithelial defect with stromal inflammation, single application, the patient. So there must be some neural regeneration also happening, although that was not one of the outcomes of this patient, and this is something worth looking at. So with the success that we've had with the cells, we have also carried on with a parallel approach with the excellular matrix. Here what we are doing is using corneal buttons which are discarded from the eye bank because of not being of optical quality. These are lyophilized, made into a powder, then converted into a hydrogel, which allows us to use material from one corneal button for many patients by expanding this. And this gel is sticky, easy to apply, and also has wound healing properties. We have just finished the preclinical studies and received the license for the GMP manufacturing, and also for starting the clinical trials for this hydrogel for application in corneal wounds, and also for injecting intrastromally for keratoconus. These clinical trials will start this year. What is also interesting about the hydrogel is that it can be used as a bio-ink for 3D bioprinting. So you basically feed the hydrogel, which is semi-solid, into the bioprinter and print tissue. So I'll show you two examples of this. One is an extrusion printer on your left, and one is a light-based bioprinter on your right. On the left, the extrusion printer is using the hydrogel to print a cornea on an existing mold, basically printing it on the shape of the mold. And on the right side, you have with the bioprinter, the light-based bioprinter, more ability to customize it to any shape, size, and curvature by doing a 3D modeling of the shape of the cornea that you want. These are currently in preclinical studies. We are hopeful that in a couple of years we will have enough data and talks and safety studies for us to go into clinical trials. So right now the preclinical trials with the application of the hydrogel-based 3D printed corneas are going on. What we are also happy with is the combination of optical clarity and strength that we have with these bioprinted corneas, where you are able to suture through them and they do not give away, which is a very elusive combination in this area of bioengineered corneas. So I think there's a lot to look forward to in the short term with cell therapy for cornea and ocular surface inflammation, hydrogels for wounds, and 3D printed lenticules, both for stromal replacement and for refractive correction. Before I finish, I just want to thank my mentor, Jim Funderburg, who set me on this path, but the great team that I have in LVPI of clinicians, researchers, scientists, engineers, optometrists, technicians, our funding agencies, and also my family. Thank you so much.
Thanks, Sain. That was a wonderful overview. Any questions from the audience? Sain, did you, I know you mentioned about the interesting case for neurotrophic keratitis. It was really impressive as well. Were you able to check if there was a return of normal sensations on the cornea?
There is improvement in sensations. We have some osteometry data. We have some confocal data also on that patient. The only thing is that looking at the nerves and the confocal was not, we didn't have the HRT3 at the time that we started the trial.
Yeah.
Subsequently we have, so we don't have like pre-application what was the situation.
Yeah.
I'm imagining, and it would not be wrong to speculate that because it's a Hansen's patient and because the patient had PED,
Yeah.
that the nerves, even if they were not functional. So there is over a period of time improvement, but that was not one of the endpoints for our trial.
Of course, yes. There was only one application?
Single application,
Yeah,
yes.
that's
So
very
I
impressive.
think with, we are hopeful that with the approval, when we do the multicentric and we get approval for using it, with, people can use it multiple times as well, or use it in other ways like subconjunctival injections or intrastromal injection. But we just have to establish, do this set of multicentric applications to get the final approval from the agencies.
So, yeah, basically we do one approval, contact lens for a week, remove the contact lens and artificial teardrops and wait?
In most cases, in the protocol, we didn't have artificial teardrops as well.
Okay.
We just had single application, contact lens, prophylactic antibiotics for 1 week, and that's it.
Okay.
And then you have the endpoints. The primary endpoint is at 1 month.
Okay. All right.
And regarding this extracellular matrix, so could you see also that the nerves are going into that gel, or the keratocytes are coming in the gel? Could you see that with some of the other
Nerves we have not seen, but the biointegration studies, biocompatibility studies have been done with the cells. So the cells do survive, and in the ECM matrix, because it is native corneal matrix, so that's not very surprising. And it also has, the epithelium also grows over it very easily. We've seen that in animals and also in vitro in the lab. So the epithelium, is able to, or it is able to epithelialize very easily once you apply it. Or if you even if you do these experiments in the lab, that you put the hydrogel and try to culture the epithelium over it, it grows very well. Nerves, we don't know. We haven't done that.
And what do you think? What is the timeline when the clinicians around will be able to use it?
So for the multicentric, you can sign up. We'll send you the cells, hopefully. So we want at least maybe 20 centers, not many patients per center, maybe a couple. But we would just want to have like a pan-Indian data so that we can go to the regulators, and because they are looking at it favorably, and we are hopeful that they will give the approval. So we just need to give them data from different centers in different parts of the country.
Amazing. Exciting time ahead.
She had one question.
So, how do you decide the dose, and what is the dose generally for the cell therapy?
So right now, the dose that we use is calculated based on the preclinical work. So there is a specific number of cells that you use in that dilution when you use them. But I think potentially moving forwards, when this therapy is available, you would be in a situation where you can titrate the dose based on what you're applying it for. And also the amount that actually goes into the eye is not the same for every case. It's just the dilution is the same, because obviously depending on the pathology you will apply more or less.
All right. Thank
right.
you.
Thank you so much.
Thank you. I'll like to invite the next speaker. Is Dr. Jang here? Please come. Yeah, sorry. You're going to talk about umbilical cord stem cells for the cornea. Thank you.
Thank you. So I'm from New Zealand, and I'm going to talk about umbilical cord stem cells for the cornea. I have no financial interest to declare. So we know that for the treatment of severe corneal diseases, corneal transplantation is the key treatment option. And there are 6 to 10 million people currently living with significant vision impairment or blindness due to corneal opacity. But only 1 donor cornea is available for every 70 people in need. And there are now increasing demands for earlier surgery with desecting and newer endothelial options. So how do we deal with this poverty of corneas? First of all, we can encourage corneal donation. In New Zealand, we've got about 80 donations per million population per year, which is not too bad compared to the OECD average of 55. But we can do so much better if we compare ourselves to the USA, which gets 366 per million. And we can look at bioengineered approaches to replacing the stroma using biomimetic scaffolds, synthetic scaffolds, or decellularized pig stroma. And for the endothelium, we can look at cultivating corneal endothelial cells from donor corneas or derive them from stem cells, such as from induced pluripotent stem cells. That brings us to the umbilical cord as a source of stem cells. It is an adult stem cell source, so it avoids the ethical issues associated with the use of fetus tissue for fetal stem cells, and it's usually discarded after childbirth, so there's an abundant supply. And umbilical cord cells were found to be multipotent, so they have the potential to be differentiated into multiple cell types of the cornea. They're immunologically naive, so less likely to be rejected, and they're non-tumorigenic, so less likely to form tumors, and they can be harvested in quite large quantities due to the size of the umbilical cords. And they have excellent proliferation properties, so keeping them alive in culture is usually not a problem. So this is a cross-section of an umbilical cord. It consists of an outermost lining membrane, enclosing connective tissue called Wharton's jelly, which holds a lot of mesenchymal stromal cells, also known as mesenchymal stem cells. And then there are 2 arteries and 1 vein within the umbilical cord, and within the vein you can usually find a reservoir of cord blood. So in our center, we've been using Wharton's jelly mesenchymal stromal cells for keratocite replacement, and the use of umbilical vein endothelium for corneal endothelial replacement. So for the first project, we isolated and characterized mesenchymal stromal cells, or MSCs, from Wharton's jelly, and then tried to determine their potential to differentiate into keratocytes. So using flow cytometry, we found that the cells that we isolated from Wharton's jelly were expressed positive markers for MSCs and did not express the negative markers as expected. And then using immunochemistry, we confirmed the flow cytometry results. So you can see the positive markers expressed in green or red in the bottom panel. And using gene expression, again, the results are consistent with protein expression, which suggests that the cells isolated from Wharton's jelly were indeed mesenchymal stromal cells. So then these cells were injected into the Sarah's human corneal buttons to induce differentiation. And we found that by 3 months, the cells have migrated and repopulated the buttons, as shown in the front-on view on the left-hand side and the side-on view on the right-hand side. And then after 3 months, we found that the cells now start to express those MSC negative markers, which suggests a shift away from the MSC phenotype. And they now start to express a host of keratocyte markers, which suggests a change towards the keratocyte phenotype. So from this project, we've concluded that the Wharton's jelly mesenchymal stromal cells have potential to differentiate into keratocytes, and the next step is in vivo testing. So now our next project is to use the umbilical cord vein endothelial cells as a source of corneal endothelial cells. So we established a culture and found that the cells express the HUVEC marker CD31, as you see on the right-hand side there. Then we tried to differentiate them into corneal endothelial-like cells. And we found that by culturing the cells in a conditioned medium from an immortalized corneal endothelial cell line, the cells turned very polygonal and corneal endothelial-like. The no treatment cells remain fibroblastic, as you can see at the bottom there. And using immunohistochemistry, we found that the treated HUVECs, even though they still express the HUVEC marker CD31, they now start to express some corneal endothelial proteins, including N-cadherin, the sodium bicarbonate transporter-like protein 11, which is a protein that's encoded by the gene SLCA4A11, which is implicated in Fuchs dystrophy. And they, most importantly, they exist as only occludence 1, the tight junction protein, along the cell borders. And then using RT-PCR, we show that the treated cells express corneal endothelial cell genes. On the left-hand side, you can see they express 2 water pump proteins and 2 junctional proteins, which are essential for corneal endothelial function. And then on the right-hand side, you can see that they expressed other markers for the corneal endothelium, including collagenase 8-2, glypican-4, the gene for glypican-4, and SLC4A11. Then using electrical cell substrate impedance sensing, we found that the cells, the treated cells in blue, have the highest electrical resistance when compared to the immortalized corneal endothelial cells in yellow, included as a control, and also compared to the untreated HUVECs in green there. And then with a bit of mass modeling, we can test for the barrier integrity of the cells from the data, from the resistance data. And we found that the treated cells in blue, once again, had higher barrier integrity compared to the immortalized corneal endothelial cells, whereas the untreated cells did not actually form a barrier. And then we found, using a dye-leak assay, we found that the treated cells had lower dye-leak across the barrier compared to the untreated. So all this suggests that the cells have higher barrier function after treatment by conditioned medium. So we've seen that the Wharton's jelly mesenchymal stromal cells show the potential to differentiate into keratocytes, and the umbilical vein endothelial cells that resemble corneal endothelial cells after treatment, and in vivo studies will be our next step. But how close are we to the clinical application of umbilical cord-derived therapies for corneal diseases? So I did a search on clinicaltrials.gov for all the studies being conducted using any part of the umbilical cord for the treatment of corneal diseases. So the first one is the use of just mashed up Wharton's jelly in an eye drop form for the treatment of chronic keratitis. And this phase 1 study in France showed quite promising preliminary results from 4 patients, showing ulcer improvement and pain improvement. And then the second one involves the use of exosomes, which are extracellular vesicles secreted from mesenchymal stromal cells isolated from Wharton's jelly. And they used it to treat chronic graft-versus-host disease-associated dry eye. And this study completed in China also showed promising results, including reduced fluorescein scores, a longer tear breakup time, increased tear secretion, and a lower ocular surface disease index. And then the third trial uses mesenchymal stromal cells themselves from Wharton's jelly, and the idea is to inject it subconjunctivally for the treatment of corneal burns. The study was in China, but the results are not published yet. And then all the other trials are to do with cord blood serum. So in this first trial completed in Korea, when it's compared to autologous serum, cord blood serum actually shows superiority in producing better symptom scores and better keratoepitheliopathy scores. And then in the second trial in Italy, when it's compared to PBS, it also showed more reduction of corneal staining, grittiness, and pain. And then there are 3 more trials with unknown results yet. So in summary, we've shown that the current clinical trials are mainly using cord blood serum and Wharton's jelly for the treatment of severe and inflammatory dry eye and keratitis. The effects were thought to be mediated via growth factors, cytokines, exosomes, and their immunomodulatory functions. Umbilical cord cells themselves have not been in any clinical trial. They would be a practical and realistic alternative to traditional stem cell sources. They have the potential to regenerate multiple corneal cell types, but further studies are required to determine the potential safety and efficacy for corneal diseases, especially stromal and endothelial. And I would like to acknowledge the colleagues who contributed to all this work at our New Zealand National Eye Centre. And I would like to acknowledge all the donors of umbilical cords and corneas. Thank you very much for your attention.
Great, thanks, G. Any questions for G from anyone? Okay, let me, so just on your, you talked about the MSCs from the umbilical cord lining for basically, and you showed, I think, that when you injected them into the stroma, they underwent some sort of differentiation. What's the percentage of differentiation? Because that might have an effect, because you're taking mesenchymal stem cells, and obviously the risk is that if you're going to give them some sort of functional effect or therapeutic effect, if they differentiate, if you're relying on in vivo differentiation, some of them may differentiate into fibroblasts, right? So is there any way, if you try to quantify the percentage that are differentiating into bona fide keratocytes, and how many, while how much have remained undifferentiated?
The short answer is we haven't done that.
Okay, all right.
But it's a good point. We should do that.
Because it might affect it. And so you're now going to do, and then the next step for this is that you're going to do functional assays. Have you tried some like functional effect to look at? Because I think did you show qPCR results basically, or you showed of the cells in the cornea, right? You showed
so the RT-PCR results are, after 3 months.
3 months in the cornea.
Yes.
Yeah. Okay. And then, because I guess what I'm trying to get at, there's 2 things, right? One is the functional effect with the basic collagen arrangement, and then the second is the production of the gags as well, which will then basically show that cells are actually producing the same effect as a normal, basically, keratocyte as well. But that, again, I guess that will give you an idea of how well they're basically functioning as well from that. The other thing I was going to ask you was, so, I mean, it's interesting, when we use cord blood serum and stuff for the ocular surface things that you basically show for, and that you showed that nice picture actually comparing to autologous to cord serum as well from those pictures. I mean, the main reason why we switched from autologous blood is that basically, to be frank, we had an issue for them getting enough blood to be able to get the autologous basically serum from the blood itself. You've got to take quite a lot of blood itself, and then it has to be basically obviously fractionated off to get the red cells off, and then basically that has to be repackaged as well. So we actually switched to basically doing this, and we can get it much faster than basically. What are they using in New Zealand clinically? Are they using the autologous serum, or are they using umbilical cord?
Umbilical cord is just trial stage.
I don't think we do. What are you guys using?
So, yeah, we can't get umbilical cord serum in the US because So we tried doing that.
Yeah.
The problem is because of the regulations, you gotta have an extra test to prove that the mom is seronegative
Yeah, correct.
towards the end of the pregnancy.
Yeah.
And they don't do that. So in order to put that
Yeah.
in, they have
Yeah.
to change a lot
The
of
whole
things.
thing.
That's the only reason we couldn't get umbilical cord serum. I used to use it in India.
Right,
It
right,
works
right.
like magic.
Yeah.
But I have to say, we do change the concentration of serum.
Serum. Yeah, yeah.
So there are quite a few patients. So we run a Sjogren's clinic. For Sjogren's, our start concentration is not 20% now. It's 50%.
Okay.
Yeah, it can cause a lot of, well, not a lot. Sometimes it can cause a bit of inflammation, but then that can be controlled with fluoromethalone. So, but 50% does. Patients are happy. So what we do is when we shift somebody from 20 to 50, we give them a mixture batch, 20 and 50, and they come back and tell us. Most of the patients will come and tell us a 50 is better.
Right.
So yeah, but I have to agree, cord blood serum, umbilical, it works much better.
Right.
Yeah.
So Vishal, we use autologous serum and not umbilical cord. The other day we had discussed and we tried it logistically, some issues. So why do you think that? So we use 20% autologous serum. So Vishal, why do you feel that umbilical cord serum would work far better than the autologous serum?
So the initial studies were actually from RP Center. I think for 2005, Radhika Tandon she had a candidate who did the thesis, and they looked at the concentration of the growth factors. So there is a significant difference. Well, I wouldn't say significant for all the factors between the serum and the umbilical cord blood. The only thing is, as I said, if you increase the concentration of serum, the TGF beta goes up. That can cause some inflammation on the surface. But yes, vitamin A, for example.
Yeah.
Serum's a little better actually than
My
cord
question
blood.
is why the umbilical cord serum seems to be working better. What was the reason for that?
I think it's because the constituents. So there's a lot more regenerative things in the umbilical cord. That's why, and that's the main reason itself compared to basically taking adult serum.
Can we just suggest that the mums give the best to their babies?
There you go.
Yeah.
So you can imagine there must be a lot of immunosuppressive agents and
Yeah,
stuff.
the other thing is, in terms
it's
of,
like AMT, right?
as Jod said, in terms of ease. So from time to time, for example, let me say this. During COVID, so we draw 2,000 blood. There's 2,000 blood draws a year in Pittsburgh where I work. You can imagine how much serum is being used. 2,000 a year. During COVID, it all stopped because nobody had a good answer. We still have people from oncology calling, well, my patient has Mets and has this and that, and they have severe dry eyes. Are you okay to take serum blood? And then we have young babies where we started using, after consenting the parents, we take blood from the mums, which is not always easy. So if you have access to something else, and of course this doesn't answer your question, why does it work better? But it does have certain advantages over serum.
So another question is that what is the percentage of your Sjogren patients who are on autologous serum, and what is your cutoff? When do you start using serum for your Sjogren patients?
So patients, so my answer is going to be slightly biased. The flow of the patients for them to be in the Sjogren's clinic. So when I say Sjogren's clinic, that clinic is a special clinic where there's an ophthalmologist and there's a rheumatologist who comes to ophthalmology department, and we work together. We see the patient. Each patient takes about 45 minutes and stuff. We work together. There's a proper evaluation. We use the SICA protocol. Usually, if on SICA protocol, if the score is more than 3, we usually put them on serum. So that's our cutoff. But I can tell you, about 90% of our patients who come to Sjogren's clinic, they are using serum eye drops.
And for you, Jyot?
We use umbilical serum for quite a lot of varieties. I'm just going to ask to get Yuchi to talk as well about it, because she runs a neuropathic corneal pain clinic as as well. And that's one of the armamentarium that they'll basically use in there as well. But we don't use autologous we're using umbilical cord, right? But mainly it's the fact that it's the access to get the thing itself, and it's now they can seem to be able to do it faster as well. And then you don't have to worry with the patients going, having blood taken, and then they have this whole rigmarole to basically go through. And the patients seem to basically prefer this itself. But there are very few, like you showed. I mean, I don't know if there's many trials. I mean, comparative to two. It's very difficult to do a clinical study where you can basically compare. Do you want to make a comment about using it in neuropathic pain?
We use umbilical cord plasma. Actually, it's not serum, it's plasma for neuropathic corneal pain. So what we usually use is intensive treatment. So usually for neuropathic corneal pain patients, I prescribe 8 times a day. So need more intensive course for initial 3 months time. And if you will see the effect, you will see patients' pain scores significantly reduced after 3 months treatment. So if you will see the effects and then continue the treatment course until 1 year time, so treatment protocol will be longer, 1 year time or even 18 months time compared to the dry eye treatment.
And so most of these patients are either like severe dry eyes or post-refractive surgery kind of patients that are having neuropathic pain itself. So they've already been through many other treatments and stuff that basically failed, and then they still have this neuropathic, photoanadynia and stuff as well, basically causing the problems. You also showed that people are using exosomes as well, right? From that therapy. And what's your thoughts on that? Because it seems to be quite interesting using a biologic for the ocular surface as well, right? Because exosomes don't penetrate through impact corneal epithelial barrier. What's your sort of thoughts on that?
I think exosomes are the next big thing. Yeah, I think they're very promising, and they're usually not immunogenic, and not likely to be rejected, and in fact it should be immunomodulatory.
Right? Yeah. Because I mean, so you do get some macrophage switching basically with exosome use, and we've been using human embryonic stem cell basically conversion into mesenchymal stem cell use itself. So you do get some macrophage switching from basically M1 to M2 class. So exactly like you're saying, so immunomodulatory effect. But certainly for ocular surface disease, it seems to be something that's quite attractive. The only issue is manufacturing it at a clinical grade level, at huge manufacturing level. It's all very well doing it for small scale studies, but trying to do it at a big scale is the issue as well. Great. Okay. Great. Any other questions from any of the speakers? No. Okay. Great. All right. So we'd like to thank all the speakers for the session. We get all the speakers to come up on stage and then on the front, and we'll just do a photograph as well. Thank you.
Recording stopped.